Hi, everyone. Welcome. My name is Mia. I'm one of the producers for TWIML Fest, and we're really excited for this session. This is Doctors and How Talking to Them Changed My Own Beliefs About the Role of AI in Healthcare. Your host today is Ranga Prasad, founder and community builder of U Plus AI, an initiative to connect humans in various endeavors with AI. Before we get started, I'd like to thank our sponsors for their support of today's session and TWIML Fest. Since today's session is hosted on Zoom, please take a second to know where the chat is. You can send any questions you have there. And if you're watching on YouTube, we are also monitoring the chat there. So feel free to send us whatever you like, and I'll turn it over to Ranga.
All right. Hi, everyone. Hope you can see me there. And let me start sharing my screen. There you go. 1 second. So hopefully you can see. Should we get started? Okay. We'll start then. I hope all of you can hear me. My name is Ranga, and thank you for that introduction, Mia. It's really a pleasure for me to be at TWIML Fest. It's definitely special, and I have a special reason that I'll tell you right at the end of the presentation. But as Mia said, this U plus AI is basically my effort to sort of connect people with artificial intelligence. And one of the first things I did there is start this U plus AI podcast, which was connected to healthcare. So I thought of it as bringing the minds together of people who are in healthcare and technologists so that we could talk about what are some meaningful ways in which AI can drive some real impact in healthcare. So that was U Plus AI podcast. It was launched this year in May. It finished season 1 in September. I had the chance and privilege to speak to about 15 medical doctors. And what I learned from them is what I'm going to be sharing today with you at Fest 2020. So the way it's going to work is I'm going to be sharing a lesson, and then I'm going to be talking about the background story of that, how that lesson came to be, what I learned, and what that means. Right? So let's get started. The first lesson is who should wield an AI hammer. We talk of so many solutions in AI, and this lesson was really driven home to me by Dr. Sriniket Raghavan, who is an oncologist, a surgical oncologist practicing in Mumbai, India. And me as a technologist, I'm gung ho about the application of technology, and many of us would have seen those research papers and exciting news in AI, where with the marvelous strides made in computer vision, there is an app which you can point at your skin, and if you take some photos of your skin, it could possibly tell you whether you have skin cancer or melanoma or not. Now, we've also heard of developments where, presented with a chest X-ray, an app could tell us, an AI-based app could tell us whether we have lung cancer or not, right? So I was chatting very excitedly with this doctor, and I was saying, "Hey, look at this. We can definitely scale these solutions to people, and we cannot train so many oncologists, so this is like a great thing, and this will really make this kind of care and specialization available, across the length of the country, especially in a country like India." Now, then this doctor sort of paused me and asked me a question. He said, "Have you ever been in a room where you've had to disclose to the patient that he or she has cancer?" And I was silent. I was dumbstruck. I I never thought of that. Uh, then it really hit me. And then the doctor said, look, whenever the specter of cancer enters the conversation, the whole atmosphere changes, right? It's whatever the stage of cancer be, whatever the patient be, it's about the doctor's empathy. It's about how the doctor, breaks even dire news to the patient before him or her. That is where is the role of a physician. So it's not so easy to just disclose that you have cancer and hey, we'll begin this treatment, and a patient would rather not hear that from an app. So that's when we talked about who should really use these apps. And then the doctor made the observation that probably, if this was in the hands of a general practitioner or a family physician, or somebody who's doing a physician practice, who knows much about their patients, who knows much about their families, their hereditary history, their food history, lifestyles, the primary care physicians, they if they had this AI assist, so to say, that would be a powerful toolkit in their tool set. And it is the general practitioners who would be able to use this app and provide the right guidance and sort of break the news to the patient and guide them in the proper manner. So that was an important lesson. Whenever we talk about building AI solutions in healthcare, we should really think who's going to use it. Are we building it for the patients? Are we building it for the general practitioners? Are we building it for specialists? Are we building it for researchers? This is so important to have this context. This lesson was taught to me by Dr. Gautam Kumar, who is a Gautam Mehta, who is a liver transplant surgeon practicing in Bangalore in India. And this is about bias exists. Now, we've heard so much about bias in all domains, and definitely healthcare is no stranger to it. Definitely bias exists, be it age, gender, whatever. But the point is that you need an approach to highlight or spotlight it. The example that we talked about is really in terms of organ transplant, be it kidney transplant or liver transplant. And what this doctor told me was that in a country like India, there is a heavy gender bias in the sense that whenever organs are donated, and we're talking about donations from live donors, most often the person who donates is a woman or a girl, and the person who receives is a man or a boy. And he was saying that even if a woman were to receive an organ, it won't most likely come from the man in their family, but it would come from some other woman in the family. Now, this is uncomfortable, but this is how it is. This is the ground truth. And this doctor, Dr. Gautam Mehta, told me this. But the point to realize is that though we may know this in different pockets of our environment and our day to day life, we need a data driven approach to collect the data, to examine it, to validate it, and then present it such that that bias becomes apparent, such that more people understand that yes, this is corroborated by data. And only when you have data and the data exposes this bias is when you can think of course correction, is when you can think of presenting this to policymakers to drive meaningful change. So, certainly, the lesson is really that we need to not ignore bias or take out parameters that will hide the bias, but have an active data driven approach to collect the proper data that can highlight this bias or that can bring it to light, because that is when we can take measures to course correct. Patients are changing. This was a lesson taught to me by Dr. T.K. Parsardi, who is a former vice chancellor of a very large medical institution in South India in Chennai. And his point was really, I talked to him about several things about how physicians can learn about the latest practices and what is the role of AI in medical education. And in that, he told me that today's patients are not like the patients who were, let's say, maybe 30, 40 years ago. At that time, due to lack of information, patients pretty much believed that doctors are gods. And, they came to them with a lot of hope that they were their last line of hope, you know and doctors did the job. But today, he was telling, as we probably all of us realize, that there is Dr. Google. Like most patients look up their medical conditions on the web, they collect more information, and not just the web. What Dr. Sarathi told me is that a lot of patients are now comfortable using digital health apps. This is a changing reality. Whether they're tracking their blood sugar level, or whether they're tracking their hypertension, they're tracking their physical activity, they're tracking their sleep, so many different parameters are being tracked. And you would have heard of the recent news of the Apple iWatch that's coming, that's going to allow you to track your blood oxygen level. And we know how important blood oxygen level is thanks to COVID 19. So, definitely, Dr. Sarathi's point where patients are changing. And his message was that doctors need to change, that solution builders need to change. They need to understand that this change is happening, right? A doctor should be able, a doctor of tomorrow should be able to understand how these digital apps work, contribute towards the development of it, because only then can they coach their patients, can they understand their patients better, and that is when patients are going to get the best care. So embrace digital health, embrace digital health meaningfully, and any apps that we build towards align to this direction are certainly going to help drive more and more change. Going further, skill is in short supply. This was a lesson that Dr. Ravi Hariprasad, who is a senior psychiatrist who practices in San Francisco, USA, and he's a mental health and wellness professional. So we all know the COVID-19 pandemic, and we all know that all our lives have been changed because of it, be it quarantine, be it lockdowns, be it the inability to socialize, to go to work, and so much. What you might have also heard is the silent pandemic, which is basically the increase in the issues of mental health and wellness that people are facing all over the world due to these changed lifestyle conditions. And Dr. Hariprasad definitely told me that the number of people that he's seeing with anxiety disorders or depression definitely has skyrocketed during the pandemic. I must have met him around June of this year, right? So, but he definitely understood that in such circumstances, and even before that, even before the pandemic, mental health and wellness professionals were certainly in short supply compared to the demand. So again, Dr. Ravi Hariprasad said that it is not that you're going to build capacity by training more professionals, by somehow increasing the number of psychotherapists or psychiatrists, but what you need to do is to use technology in meaningful manners. For example, um, AI-based, machine learning-based technologies could be used to screen a large number of people to triage who needs the help the most. Help could also come in terms of digital health apps. For example, recently, the US FDA approved a video game. I forgot the name. Basically, it is a video game that can help children with ADHD. Children who have ADHD, they can be helped in a therapeutic manner by playing this video game, right? And that is US FDA approved. So again, sort of a digital software solution to a real problem. So certainly we need to acknowledge the skill is in short supply and use technologies like AI and machine learning to scale that access, use it for screening and also in monitoring. For example, somebody who makes a visit and then goes back, is that person adhering to the medications? Is that person has changes in lifestyle? Is that person's sleep pattern regular, their exercise pattern regular? Because typically what results in good mental health is really a good exercise or active lifestyle, sleep, and diet. These are the basic factors, right? So, definitely, technology can be used in monitoring all of these. So, certainly, that is also a lesson that was driven home very well by Dr. Ravi Hariprasad. This is an interesting one. Use what works now rather than wait. So this was in conversation with Dr. Himanshu Gupta, who is an orthopedic surgeon and a spine care specialist who operates out of Gurgaon in near Delhi in India. So, he's a person who has been using telemedicine of sorts, certainly, exchanging messages over the phone with his patients and, collecting information about them when they try to make their first visit and all that. But with the pandemic, he had a unique problem. In the sense, patients were not able to come to his clinic because of the total lockdown in a place like Delhi. And at that time, telemedicine apps, at least in India, platforms were not in vogue or were not very widely adopted. So, what he turned to is he started using WhatsApp video calls. Now, it turns out that at that time, there could be only four participants in a WhatsApp video call. And that turned out to be a problem for him because what he said is a lot of his patients are elderly patients, right? Uh, so when elderly patients, they typically come to the doctor, the doctor explains them, they ask multiple times to understand what they are. And then, they possibly get a printout, a prescription, and so many things. So then they have the complete picture of the information. Now, over a WhatsApp video call, right, it's a bit hard. So they would typically want their children who are in other cities or in other countries also to log into the WhatsApp call to understand what's going on, right? And obviously, their children are also in, COVID affected and they are in lockdown. So they would also have the interest to know what the doctor is going to say to their parents. So this presents an interesting challenge for Dr. Gupta because in a typical WhatsApp call, he would be there, his assistant has to log in, then some person who does the administration and billing was logging in, and then he had one slot for the patients. But now he needed to open up more slots because they were the patients, relatives, and children from other parts of the world who wanted to, come in on that call. So he had a challenge where he had to drop, some people or the other to make it work. Now, luckily, during that time, apparently WhatsApp increased the video call participation to 8 participants, and that has really helped him. So again, the lesson really is Dr. Gupta quickly adapted to what he could work with his patients. It may not be the perfect solution, it may not, tick all the boxes, but it certainly helped. And over time, obviously, with the WhatsApp video call participants increasing to 8, that helped his cause. And now he's probably moved on to a proper telemedicine platform and all that. But the lesson for me really is when we are building solutions, most often we will find that people will use what works now, what meets their use case, rather than wait for a perfect solution. So it's rather that we build and iterate and release it and iterate on it depending on what people like, rather than sit back and build the perfect solution. Moving on, no knowledge is too simple to share. This was a lesson from Dr. Sandhya Ramanathan, who is a general practitioner practicing in New Zealand, in Auckland, New Zealand. Of course, she made a YouTube video, which is called Home Management of Mild COVID 19. And she made it because, she wanted to help her family. She wanted to help her patients just about the time when New Zealand was going into lockdown, into a very strict lockdown because of the COVID. And she figured that she was not able to handle calls from of her family and friends from all over the world trying to understand more about COVID-19. So she made this video. Now, little did she know that this would become viral because somebody picked up this video, shared it on WhatsApp in India, and it basically spread like wildfire. Now millions of people, note the point, probably tens of millions of people have watched this video, and her video is translated into multiple languages, and she has got feedback from all over the world that how this video has really helped people. Now, when I talked to her, what she was saying is, whatever the stuff that she shared in that video is not rocket science, is not complicated. These are very simple tips and very simple information that you, me, everybody can consume and take simple steps to sort of manage COVID-19 at home. If any of us or any of us in the family were to get it, what all we need to do. But basically, what resonated was the simplicity. And so her belief, and the lesson that I take from her, is that sometimes we kill our own ideas. You know, take me for example. When I was trying to write a blog, or start a podcast, or share something, a tweet or something, there's always this debate in my head saying that, oh, people already know this. Why am I even sharing this? This is like so obvious. Turns out that many times we kill our own ideas, and we think, we try to set a higher bar. But the fact of the matter is, people like simple knowledge. People consume simple stuff, easy to consume stuff, and that is valuable. And you never know what that knowledge could translate to somebody else's life. A case in point being Dr. Sandhya Ramanathan's video, which people have written to her that it has literally saved their lives. So, really, when we build AI solutions and machine learning solutions, I take it that we should really not neglect the simple in search for a more complicated problem. Simplicity, if you are able to present what is existing in a simple manner and solve simple problems, there definitely is a huge market there, and people will really appreciate you for the effort that has gone into it. So, definitely something to think about. Even the best design solutions need to adapt. Again, this sort of ties in with the previous one about simplicity. This was a lesson from Dr. Amitabh Gautam, who is a transplant specialist, a kidney transplant specialist who practices in Boston. He has a long and distinguished career, both in India and the US. And with him, we talked about the kidney allocation algorithm that was adopted in the US probably 4 to 5 years back. And the whole point of this algorithm is, there are a lot of people with end stage kidney disease who are on a wait list waiting for an organ from a donor. And as organs become available from donors, be it live or dead, there has to be a mechanism that decides how this organ is going to go, who should it go to, given a certain criteria, who should it go to on the wait list. Now, this to obviously earlier it was not an algorithm; it was done more manually. But over the years, over history, this has become more automated, and there was an algorithm that came into force. Now, the key thing to note is, to bring this algorithm into force, there was a 10-year process. It consulted all the stakeholders, be it technologists, be it physicians, people from society, people with suffering from this disease, experts, researchers, you name it. It was a 10-year consultative process with many iterations before the algorithm was finalized and really deployed. But the key thing is, once it was deployed, it was really the best design solution at the time. Still, once it was deployed, there were calls from groups of people, or what you call subpopulations, that their needs had not been met adequately by this very well designed algorithm. One of the groups was a group of people who needed a pancreas and a kidney at the same time. So basically, their contention was that this algorithm did not meet their need. In fact, there was a more famous case of somebody who needed a lung transplant. And this was, of course, about kidney allocation. The same process had been adopted for lung transplant as well. So there was a person who sued the UNOS, which is the body that sort of implements the kidney allocation in the US, saying that in her case, there was geographical discrimination, right? She was not able to get the lung, even though she was the closest to the organ availability, just because she was not in the same state. And actually, the US Supreme Court had to intervene and give a timeline by which this issue had to be resolved. So, certainly, again, one more case where even the best design solutions, when we design them from an AI and ML point of view, they really need to adapt to the changing needs of the people and the populations on the ground. So that's definitely something that we should think about. And what that also means is that there is no perfect solution. You have a solution, you look at the needs, and you iterate and adapt. Best practices are lessons learned from failures. This was from Dr. Pata Radhakrishna, and he has a very vibrant Facebook community, of surgeons and medical practitioners, where they discuss, among other things, the lessons that they learn from failures. And when I talked with him, I talked about, why we can't have a more broader engagement, because these lessons are really important, whether they are lessons from, treating people or from surgical procedures, you know, uh, where things have failed and what people have learned from it. So what Dr. Pata Radhakrishna told me is, yes, it can be done. And certainly the best lessons are from failures. And that's where best practices come from. But the trouble really is that when you collect this data, can you guarantee that this would not point back to an individual? Can you have measures of privacy? Can you have measures of de identification? And really work on the aggregate of data rather than on the specifics. And that, if you're able to do, then is when we can really, harness the power of the lessons that are learned from failures. So certainly, I think I don't know if such solutions are there. I mean, I have talked to some doctors as well, and I've corresponded with some people on, in the field, but I am not aware of any broad platform or a solution where this kind, which meets this kind of a need. Even like, what are the best surgical practices for doing gallbladder surgery? I mean, I'm sure there's so many surgeries happening around the world, but is there something that is distilled from failures without the ability to, point back to people? I think that's something we certainly need. Going ahead, the point of care is shifting. Now, we have seen this with the COVID-19 pandemic. Certainly, people are not able to go to the clinics. They're not able to go to hospitals because of fear of contraction of COVID-19. This is basically, when you look at AI in healthcare, when you look at the future of healthcare, I mean, you would have heard this in other places too, is that the point of care will be where the patient is. The point of care is not a specific place like a hospital or a clinic or whatever, but the point of care will be where a patient really is. So that's really the idea. So this was, of course, told to me by Dr. Chitra Selvin, who is an endocrinologist, diabetologist, who is practicing in Bangalore. And she was saying that many of her patients who come to her for diabetes consultation, maybe 30-40% of that, they need not even come to her. I mean, a phone call would suffice, or like, a weekly email or perhaps an app which kind of tracks their blood sugar level and their diet or their medications would be enough. There is no need for them to really to come to her and get her advice. All they need is some kind of a diabetic coach, which can sort of prod them, on a daily basis at the right times, to manage their diet, to manage their exercise, to manage their adherence to medications. And that is how they can manage their diabetes, because it's a chronic disease, and they can manage that through their life instead of having to consult a physician every time. So certainly, again, that's an example that the point of care is shifting to wherever the patient is. So if we are designing solutions, digital health solutions or AI in healthcare solutions, if they are aligned to this kind of a trend, then I think we are in the right direction. This is certainly an important idea that we need to keep in our mind as we move ahead. And finally, being human is the cornerstone of the doctor patient relationship. Now, this was a lesson um, that was driven home by Dr. Tia Gopalan. He was my first guest on the U Plus AI podcast way back in May of this year. And I regard him not just as a guest, but he's been a mentor to me for all things healthcare. And he put it so eloquently, about this very fundamental point of the doctor-patient relationship. What he said is that yes, we can have technological interventions. We can have speech to text to understand what goes on between the doctor and patient. We could have video analytics. We could have apps which could extract all the patient data, different kinds of history, their dietary history, their family history, their lab results, everything into a nice way, and sort of present it on a timeline or a dashboard, such that when the patient comes to the doctor has complete information. I mean, these are all things that we could do, you know, and definitely they will use AI and machine learning for many of those things to come true. But what Dr. Gopalan very eloquently put at the end is that ultimately the patient requires the doctor to be a human. The patient wants the doctor to listen to him or her, to have soothing words, being told to him. And Dr. Gopalan said they probably want their doctor to touch them, to have an understanding arm around them, and even if their diagnosis is very grave, to give them hope, to have empathy, to talk to them in a very meaningful and concerned manner as a fellow human, and not just talk to them, but talk to their family, maybe their spouse, maybe their parents, maybe their child. A human talking to other members in their family and explaining how they will manage this condition or the disease that has been diagnosed. So I think that is really a key point that we need to keep in mind. We can design AI in healthcare solutions. Certainly, there is a tremendous opportunity, but we need to keep in mind that are these solutions fostering the human connection between the doctor and the patient? Anything in that line certainly has great potential, because ultimately, as Dr. Gopalan said, I repeat once more, the patient requires the doctor to be a human. So at the end, I have put all the lessons in one slide and the doctors that I talked to. This could be handy if slides are shared with you. You can go and take a look at this. These are all links. You can go click. You can go know more about these doctors, what they're doing, and what they had to say. So definitely, this will be something that will be handy for you. And it's like a one shot where all these lessons that I've learned and I've shared with you, I hope you also benefit from them. Lastly, thank you. And I told you at the beginning that I will share, some connection with TWIML. The connection is really that when I was beginning my U Plus AI podcast in May, I pinged Sam Charrington on Twitter and I asked him, Sam, give me some tips about how I take forward this podcast, because you've been doing great with TWIML, and you're one of my, I'm your fan, right? Because I listen to TWIML episodes so often, and I've been doing that for the last 3 years. And Sam was very nice, and he wrote back to me, and his lesson to me, which I follow, is be consistent. His point was that you show up at whatever cadence, every week or every 2 weeks or whatever, but do show up. uh, Not like you do one podcast episode and then disappear for like 2 weeks, another podcast episode you disappear for 3 weeks. His real lesson was be consistent, and I've been trying to do that, Sam. So thank you so much for Sam and the Trimble team again for giving me this opportunity. I thoroughly enjoyed it, and thank you to everyone who has shown up here. Definitely in India is late night, and I'm sure other places also. People have taken time out from their schedule and tried to be here. I am very, very grateful to you that you came here. Hopefully, this was interesting for you, and I'll be happy to hear your comments, suggestions, tips, whatever. And let's connect. You can always connect with me on Twitter at U+AI, and you can look up uplusai.com, where I have all my podcasts for season 1. And season 2 has just begun a few weeks back. Just yesterday, I released episode 2. So you're welcome to follow that as well and give me constructive feedback. So the floor is open. I hand it back to the host. I will stop my share and I will take questions. Thank you so much.
Thank you, Ranga. If anyone has questions, please feel free to unmute and show your video if you like. We'll hang out here for questions, and also in the YouTube chat, feel free to send anything there.
While we're waiting for questions, I just want to say thanks, Ranga. Great presentation. I really enjoyed it. The lesson that jumped out to me was the story about the doctor that posted the very simple video about home care for COVID,
Right.
and your comment about how we often filter, sharing things that we know. I'm certainly guilty of that as well, or suffer from that, however you want to put it. And so I appreciate that lesson. Congrats on the consistency with the podcast, and keep it up.
Thank you. Thank you, Sam. So is there a question? Do I see a question on the chat or something?
Yeah, there's a question in the chat. Phil, if you wanted to unmute and ask in person, or I can read it out as well.
Sure, I can unmute. You mentioned kind of an examination on who's utilizing the technology. So you mentioned the practitioners or the patients or, more long-term planning
Right.
needs. One of the questions I had is a lot of interesting new technologies have come out for pre-screening different conditions. So my question was, have you seen this utilized in the clinical setting yet, to where doctors are using some of the pre-screening mobile applications or voice assistants that we've heard so much about during the conference?
Right. So yes, in pockets, I would say. For example, definitely in India, I've seen this app or this solution where they use interpretation of chest X-rays to diagnose tuberculosis. There are trials going on in Rajasthan, in a state in India. I've also seen, Google came out with the solution of detecting screening for diabetic retinopathy, like because of diabetes, if you have an eye disease or, so that I know that there was a trial going on in one of the hospitals in India. It's a famous eye hospital called Shankar Netralaya. I think it's Shankar Netralaya or Urban Eye Hospital, the other big chain. So definitely there was a trial going on where this technology was being trialed. Of course, I wouldn't call it like regular clinical use, but it's probably part of a pilot or a clinical trial where these technologies are being used so that they can get an idea of how broadly they can be deployed. So thanks, Phil. I mean, definitely those are two examples that I'm aware of.
I see another question from Sanja in the chat if you wanted to come up and ask. I can read it out. So the question is, are patients ready for digital health solutions where they have to take care of their own health? What do doctors think about it?
I think we're seeing some early evidence of it. Like I said, definitely. I mean, I know people in my family, but that's just anecdotal. But I've heard from doctors where this diabetologist that people are certainly using an app that tracks their blood sugar level, right? And it gives out some neat reports, your weekly trend or your monthly trend. So that is something that definitely people are using. Uh, Especially diabetics who are on a long term, they're certainly kind of using that. And I've heard from this, like I said, the orthopedic surgeon and spine care specialist, Dr. Himanshu Gupta from Gurgaon, Delhi. He has definitely, he's actually asking his patients to use some of these technologies, and they are using it more for more for monitoring their post procedure. Like, let's say they've had a procedure, or they've gone to for a certain consultation, and they've come back. Now they want to monitor their progress, whether let's say somebody who's had a knee transplant. Doctors really look at how quickly they can come back to their walking state, what all they're doing in the weeks that follow. So for those things, definitely there are some apps and digital technologies that are being used. Obviously, we are aware of technologies like like trackers, which track our physical activity, and sleep trackers. So again, that is something we are seeing. Definitely I heard from the mental health professional that, because sleep is such an important component, uh, something like a sleep tracker is very essential to know that whether the person has had proper sleep during the last week, or let's say last 10 days or whatever, right, during a certain period. So definitely that is also one more area. Thanks for the question.
Great. And we have one in the YouTube chat as well from Hamad. What do you think governments can do to bring medicine in the 21st era globally?
I think a lot. So, I mean, we could talk, probably an hour. I'm sure there are better experts than me to answer that. But, a few things is, one is making it affordable. Definitely in countries like India, if you can use technology to scale out, to really reach the fringes of the country, that is something that will be very valuable. The second part that I think will be really useful from a government point of view is access. Like there are so many people who, even if they are in urban centers or cities, they are not able to access, healthcare because for whatever reasons, because the demand is so much, or they don't have a hospital nearby, or they are not in a state to travel to the clinic or the hospital. So again, technology can certainly be used to give access to populations that were not able to get access to it earlier. The other way I see is, definitely we can use apps and these technologies to screen at bigger scale. So for example, if we want to know, let's say the scale of diabetes in a city in India, right? Are you going to have, are you going to do door to door and go do a blood sugar test, or things like that? Maybe the cost may be prohibitive. So will you use technology to kind of do that screening? Maybe if you're able to collect data about their diet or about their exercise, or other habits, if you're able to collect data and sort of infer from that, then that is probably like a screening tool. So these are things that definitely I think governments, again, not I'm just not talking about the federal government, but even the local government in your city or your council. I mean, if they have the right tools, I think they can roll it out to their populations to understand them better. Thank you.
I see one more in the chat. What are some of the popular health apps used in India?
See, one of them that I know is there's an app called My Sugar, MYSUGR. I think that's the one that is used by a lot of diabetics to sort of record their blood sugar levels. So that's certainly one. Yeah, I mean, there are other smattering of this, but I've not seen something more broadly used as for a condition. I mean, there are solutions, like I said. I think Cure.ai, Qure.ai is a startup, a company is focusing on diagnosing tuberculosis or lung cancer from chest X-ray interpretations. But again, it's not a digital health app in the hands of like an everyday person, but it's more being designed for healthcare providers and practitioners. Thank you. More questions?
So, hi, it was a very nice talk. With Madhu, I learned a lot. I had one question here. I think you spoke about 2 points, mental well-being. I was just trying to think, see, many times we just say that talk to ourselves, or, if there's a friend we feel expressed and then we come out of the situation. But I don't know, how do you see conversational AI coming in as a, it's as a digital friend trying to allow to express? Does it get expressed or not? That's one question. The other question on your last slide, I think the doctor patient connect, I think, do you see AI as a way coming knowing the personality profile of a patient and then trying to recommend doctors on their sensitivity levels, so that thereby the doctor also is a human, right? We cannot make him like someone who can take all the emotions of all the patient, but then how do we balance that, right? So that these are the two questions I had. Otherwise, it was a enlightening talk. Thanks.
Well, thank you so much, Madhu. Certainly, to your second question, yes, certainly possible, but obviously we would need to mine the data, understand the patient more, and understand the doctor more, right? And if you're able to understand, I mean, when I say profile, you're talking about emotions and how they react to situations. So we would have to really build a profile based on, their past activity and how they are, and how they react to some situations, and therefore do a matching, right? So possible, yes, but whether that'll happen, I mean, that remains to be seen. That's definitely a question that's out in the open. um, Regarding your first question of conversational AI in how it can help in mental health. See, when I talked with Dr. Ravi Hariprasad, we talked extensively about how tech can help, right? So one of the ways is what they call predictive behavioral analytics. So what Dr. Hariprasad was saying is, from the way we use our mobile phones or the way we interact in social media, how often do we pick up the phone? How often do we, log into it? How often do we open Facebook or WhatsApp or whatever? All of this is leaving a what you call a digital exhaust, right? So if you're able to understand the digital exhaust of a person, certainly you build a certain understanding of who they are. And in Yuval Noah Harari, who's a famous author, this 21 lessons for the 21st century, he says that AI is bringing a time where it knows probably more about you than you yourself, right? And I feel that applies here, because sometimes the way I'm interacting in social media, I may not be able to verbalize what I'm thinking, what my emotions are, but the way I write, the speed with which I write, the speed with which I change tabs, and on which platforms I write and which times of the day I write, when I don't write, based on all of this, there is a certain profile of me that's being built. And that is something that, even though I may not verbalize, there is some understanding that is built of me. And I also remember Facebook, right, at some point claiming that they will be able to understand people on their platform who have a greater risk or propensity to suicide. Now, you can certainly imagine how this could be possible, right? I mean, today we know that Facebook is able to target ads to us very well based on our preferences. So certainly they have understood something about us. So I think the same can be extended to understanding us at a more, deeper level, like, what our emotions are, or how we are interacting and how we are reacting to situations. So while I find it strange that some AI can do something like that, I don't really think that that is out of the park, or that's gibberish. Certainly, it's possible, and it's being done even today. Thank you, Madhu.
Yeah, thanks, Munga. It was quite insightful, the AI side of things, how it really works. Okay, thanks.
We have another question in the chat. During your discussion with doctors, did you ever get an idea about a desperate need for an AI or ML tool to solve a medical problem that would save more people?
Yeah, certainly. I mean, many such ideas, right? So, something like, we've heard about hospital-induced infections, right? People in ICU, they develop some infections. Sepsis is the most common one. And I did talk with Dr. Ron Daniels, who is a founder of, the UK Sepsis Trust. And definitely, if we had a tool that could understand the parameters of patients who are in ICU, the different vital signs, and if it could predict who is going to develop sepsis or give an idea of who's going to develop sepsis, definitely you could act more faster. And if you did act fast, then you have a chance to probably save that person. Or an early intervention will prevent a what you say, a more complex situation from developing. So certainly that is one thing. Of course, we talked about, like I said, we talked about mental health and psychiatry quite a bit. Certainly, if we had the right tools, I think we could help a lot more people. um, I've talked to about a company that is doing breast cancer analysis, not using mammograms, but using thermal cameras, using thermal imaging. Now we are all familiar about thermal imaging because if you've traveled through an airport or to a mall, even in the COVID-19 pandemic, you would know that there are thermal cameras kept at the entry points and they try to check your temperature. Now, the same idea can be used to check your chest congestion. The same idea can be used to, image and take an image of the breast and indicate whether there is cancer or not. I mean, there is a company in India called Diramai, which is doing exactly that. Of course, I mean, again, they've been there for a few years, but it may not be in deployment, in a broad scale deployment, but certainly they're using technology in interesting ways. And imagine if you're able to do that using thermal cameras, how easily you could scale that solution rather than having a radiation based mammogram that is required to detect breast cancer early. So I think these all solutions, uh, any and all, if we can develop for a specific need, I think we will definitely, make a dent in saving people's lives. Thank you, Umashankar, for that question. Well, that's good to see. I mean, there are a lot of questions, so thank you so much. I mean, it's been a real pleasure to engage with all of you, and an interactive session also makes it very nice.
Ranga, there's one more question in the YouTube chat.
Sure.
Do you think communication in emotional terms when you're trying to chat and put information across to others? So I think it's do you think in emotional terms when you're communicating with people?
Is it a question for me or is it a question for an AI solution when you say, do you think in emotional terms?
I'm asking for an expansion on that question.
Okay.
I believe it's for you.
It's for me? Okay. When I talk to people, when I think in emotional terms, if that's the question, yes. I mean, I think humans are emotional, and we do forge a connect with when we talk to a fellow human. So definitely, I think emotions are not out of the park. They're very much part of the conversation, be it virtual or be it in person, face to face. If that is the question.
Yeah, I think that was it. Thank you.
Thank you.
One question, if it's okay.
Go ahead.
Yeah. Thanks a lot for the talk, by the way. Really enlightening. One question that I have is, so just following on from the previous question with the emotions. So as a human, definitely, I know I can connect with another human being. I can provide with the right emotions that is needed for that specific situation. But as an artificial intelligence, as a machine, I feel that context, that emotion has not been captured so far in any technology. I could be wrong. But do you see that happening anytime in the future? And if so, what type of technology is closest to achieving that sort of emotion?
That's a good question. I don't know. Maybe I'm not the expert, but I don't believe we are there yet. So, for example, one of the simple tests that I do, when I'm engaging with, let's say, any customer services, I always try to guess whether the thing that's talking to me is a bot or a human, right? And simple things like a bot will not make spelling mistakes, right? A human will. A bot replies very quickly, because the answers are almost like that. But a human will, you can see that the human is taking some time to type. Okay.
Yep.
So these are small cues I will use to say, whether it's a bot or a human. And also, like, a bot is typically will have very canned phrases like, please and sorry and all that. A human, if you have a little bit lengthier conversation, the phrases will be different and there will be spelling mistakes. There'll be, uppercase, lowercase errors and all that. So I think and I'm making this example just to drive home the point that probably chatbots today, even though they try to mimic humans, they're not quite there. They can be found out, right? They don't have that kind of emotion. They cannot react to that situations, right? And obviously you might have seen cases of chatbots. They've gone horribly wrong. They don't pick up sarcasm, right? So and these are very human traits and human emotions. So I personally think, I don't think we have it there, but uh, probably Sam, I don't know, I'm not wanting to put him on a spot, but he's talked to much more AI experts to see if emotion AI is on the horizon.
Okay.
Yeah, there are definitely people working on this. The folks that come to mind are folks like Rana Al-Kayubi at Affectiva. There's another one that one of my very first interviews was on this topic. And I will try to find the link to that. And Amari, if you're listening and you remember the name or the link, you can chime in as well.
Well, thanks, Sam. At least we know one, right? Affectiva, Rana Al Kalubi. So I think that is that's really good.
Yep, and I'll
Very
drop
good.
the other one in the chat when I find it.
Sure.
Thank you so much. Yep.
And thanks for the question. Really, really important one.
Yep. Thank you so much.
I think this can be the last question, then we do have to wrap up. There's a few links coming through in the chat though for anyone interested. This question is, even with false positives and lack of explainability, do you see value for AI adoption for early detection for various healthcare? Can it address affordable care at a human population scale and challenges?
I think affordable care, yes, because I think, I look at what the alternative is, right? If the alternative is to train more specialists, if the alternative is to have more doctors, more nurses, more human people training and all that, I think you're not going to scale that to, the population levels of the earth, right? So certainly you need technological interventions, and probably one of the best technological interventions you can have in this space is, use of AI and machine learning. Now, the question about false positives is certainly a very important one, because, again, it depends on the context, right? So where is it okay to have a false positive, where it is super critical not to have one? So I think that needs to be decided on a case to case basis. For example, even with COVID, right, we had this AI app, computer vision app, which could detect from a chest x-ray whether the person was likely to have COVID-19 or not. Yes, it had a false positive rate. So would you deploy? So as a provider or as a healthcare provider, what would be the acceptable false positive rate for you to apply? Now, maybe in this case, false positive is okay, but false negative is more dangerous, because if you didn't detect somebody who had COVID and that person went out into society and you basically said he or she doesn't need to quarantine, then you're actually causing a bigger problem. So I think the context matters a lot, to whether it should be a false positive or a false negative, and what is the level that you can tolerate. Thank you for that question.
All right, thank you so much for all those great questions. We do have to wrap up. Thank you so much, Ranga, for hosting. This was a really cool session. Thank you everyone for attending. The video will be available on the session page as well as on our YouTube channel. And be sure to reach out if you have any further questions. And thank you so much, everyone. See you soon.
Thank you so much.